If you are over 60, one of the most dangerous things you can believe is this, that there is one perfect blood pressure number for every older adult. I need to tell you plainly, that is not how real medicine works. For years, many people were taught to chase one number, usually 120/80, as if lower is always safer. But in older patients, that idea can become misleading, and in some cases, dangerous. I have seen patients with good blood pressure on paper who were exhausted, unsteady, foggy, and one step away from a fall, a fainting spell, or a trip to the emergency room. Here is the real issue. After 60, your arteries change, your pressure sensors change, your brain and kidneys may not tolerate the same blood pressure pattern they did at 40. And that means the best blood pressure for a senior is not just about looking normal on a chart. It is about protecting the heart, the brain, and the body without pushing pressure so low that the person becomes weak, dizzy, or unstable. Research from major trials, including SPRINT, suggests that lower systolic pressure can reduce cardiovascular events in selected older adults. But clinically, what we see is more nuanced than the headlines. The number matters, but the patient matters more. And here is where it gets serious. Some seniors are living with blood pressure that is too high and do not know it. Others are being treated in a way that looks correct but feels wrong in the body. So let me ask you a direct question. When you check your blood pressure, do you only look at the number, or do you also pay attention to how you feel? Because in a moment, I am going to show you why that distinction can change everything. Why does this question become so important after 60? Because the aging body does not handle blood pressure the way a younger body does. As we age, the large arteries become stiffer. That means the top number, the systolic pressure, often rises, even when the bottom number stays normal or even drops. This is called isolated systolic hypertension, and it is the most common blood pressure pattern I see in older adults. Many people think, my bottom number looks fine, so I must be okay. Not necessarily. A high systolic pressure can quietly damage the brain, heart, kidneys, and blood vessels for years before it causes obvious symptoms. But here is the other side of the problem. And this is the part most people miss. In patients over 70, blood pressure that is pushed too low can also create trouble. Why? Because the brain depends on steady blood flow. The heart muscle depends on pressure to fill its own arteries. And when pressure drops too much, especially when standing, some older adults become dizzy, weak, foggy, or unsteady. Orthostatic hypotension, a drop in blood pressure when you stand, is not rare in later life, and it is linked to falls, fractures, fainting, cognitive decline, and even higher mortality. So this is not just a conversation about numbers. It is a conversation about function. Can you stand up safely? Can you walk without lightheadedness? Can your brain stay sharp? Can your treatment lower stroke risk without increasing fall risk? In my experience, this is where many seniors get oversimplified advice. They are told to chase a number but not taught to watch the signals their body is sending. And in the next section, I'll explain the first major truth that changes how I look at blood pressure in every patient over 60. The first clinical truth is this. For many seniors, the question is not, how do I get to 120/80? The real question is, what pressure range protects me without destabilizing me? That is a very different conversation. In my 25 years of practice, I have seen older patients become obsessed with one target number. They bring me home logs, they circle readings, they panic if they see 138. But they do not ask the more important question. What happens to your body at that pressure? Are you steady? Are you thinking clearly? Are you short of breath? Do you feel weak when you stand up? This is where the 120/80 idea becomes oversimplified. In younger adults, that number may be a useful benchmark. But in adults over 70, especially those with stiff arteries, kidney disease, frailty, or multiple medications, the best blood pressure is often a range, not a slogan. Research from SPRINT showed that in selected high-risk adults, including many aged 75 and older, Treating systolic pressure more intensively reduced cardiovascular events and mortality. That matters. It tells us that uncontrolled systolic pressure is dangerous and should not be ignored. But it does not mean every senior should be forced toward the same exact number under all circumstances. And here is why that nuance matters. In very old adults, the top number often rises because the aorta and major arteries become less elastic. The heart ejects blood into a stiffer system, so systolic pressure climbs. That means a reading like 150/70 may carry a different meaning in an 80-year-old than in a 40-year-old. In the HIVET trial, adults age 80 and older benefited from treatment aimed at a target below 150/80, with reductions in mortality and heart failure. That should immediately tell you something important. Even strong clinical trials in the very elderly did not start from the assumption that 120/80 was the only acceptable goal. So let me ask you a direct question. If you are 78, feel stable, and your systolic blood pressure is in the 130s, is that a failure? In many cases, no. If you are 78, your reading is lower, but you are dizzy every morning and nearly falling in the bathroom, is that automatically a success? Absolutely not. Here's where it gets dangerous. People confuse a pretty number with a safe outcome. And in the next section, I'm going to explain the number most seniors are not paying attention to, and why that mistake can quietly increase heart and brain risk. The second point is one many seniors never hear clearly enough. The bottom number matters more than you think. Most people focus only on the systolic pressure, the top number. And yes, that number is important. But in older adults, I also watch the diastolic pressure, the bottom number, very closely. Why? Because your heart muscle itself gets much of its blood flow during diastole, the relaxation phase between beats. If that bottom number falls too low, the heart may not be getting the pressure support it needs, especially in an older person with narrowed arteries or long-standing vascular disease. This is where many well-meaning treatment plans can become too aggressive. A senior may have a systolic pressure that looks improved, but the diastolic pressure may drop into a range that is not ideal for that individual. Research published in JAMA Network Open suggests that when treated, diastolic blood pressure falls below 60 mmHg, cardiovascular risk can rise. In that analysis, the lowest risk was seen in a diastolic range around 70 to 80 mmHg. That does not mean every person must aim for one exact bottom number, but it does send a very clear warning. Lower is not always safer. Clinically, what we see is this. The older the arteries, the wider the pulse pressure often becomes. In simple terms, the top number rises while the bottom number stays low or drops lower. A reading such as 158/58 may not look dramatic to a patient who only hears, "Your pressure is coming down," but to me, that is a signal to slow down and think. Is this person being protected, or are they being pushed into underperfusion? Here's where it gets dangerous. Some older adults do not feel classic chest pain when blood flow is marginal. Instead, they feel fatigue, weakness, brain fog, shortness of breath, a strange pressure in the neck, or simply, "Doctor, I just don't feel right." So let me ask you something. Has anyone ever explained your bottom number to you? Or have you only been told to worry about the top one? Because this is the part most people miss. A blood pressure plan that lowers risk on paper can still create instability in the real world if the diastolic pressure gets too low, especially in patients over 70 with stiff arteries, coronary disease, or frailty. And in the next section, I'll explain why the way you measure blood pressure may be almost as important as the number itself, because some seniors look stable sitting down and become high risk the moment they stand. The third truth is this. A blood pressure reading taken in one position at one moment may completely miss the real danger. I have seen this many times. A senior sits in the exam room, calm, supported, feet on the floor. The number looks acceptable. Everyone relaxes. Then that same patient stands up, walks 10 steps, and suddenly feels lightheaded, weak, or unsteady. That is not a small detail. That is a warning sign. In older adults, Blood pressure can look controlled while sitting and become unsafe when standing. This is called orthostatic hypotension. A drop of at least 20 mm Chang systolic or 10 mm Chang diastolic within 3 minutes of standing. And according to the American Heart Association, it becomes more common with age and is linked to falls, fractures, syncope, cognitive decline, frailty, and even early death. Now think about what that means in real life. You do not live your life sitting perfectly still in a clinic chair. You get out of bed. You stand up from the toilet. You walk to the kitchen at night. You go down steps. That is when the real-world test happens. Here's where it gets dangerous. Many seniors assume dizziness is just old age. It is not. It may be a circulation warning. It may mean your brain is not getting enough blood flow fast enough when you stand. The National Institute on Aging even warns older adults to rise slowly because lightheadedness upon standing can lead to falls, especially when blood pressure medicines are involved. This is also why I do not judge treatment by office numbers alone. Clinically, what we see is that harms from more intensive blood pressure treatment can happen early: fainting, hypotension, weakness, medication side effects, while cardiovascular benefits often take longer to appear. Research in JAMA Internal Medicine suggests that this balance should be individualized, especially in older adults with frailty or limited reserve. So here is my question to you, and I want you to answer it honestly. Have you ever felt dizzy, weak, or unsteady when standing up? Comment yes or no below. Because if the answer is yes, this is not something to brush off. This week, check your pressure sitting and then standing, and bring those numbers, along with your symptoms, to your doctor. And in the next section, I'm going to show you why some blood pressure goals that look impressive in studies can become risky when applied to the wrong senior in the wrong way. The fourth clinical point is one I wish more seniors understood. The best blood pressure is not determined by age alone. It is determined by reserve, stability, and risk. Two people can both be 78 years old and have completely different safe targets. One is active, sharp, walking daily, with strong balance and good kidney function. The other is frail, on 6 medications, gets dizzy in the morning, and has already had one near fall. If you give both people the exact same blood pressure goal, you may help one and harm the other. This is where headline medicine becomes dangerous. Research from Sprint showed that more intensive systolic control reduced cardiovascular events and mortality in selected high-risk adults, including many older participants. But look carefully at who was actually studied. These were adults who were monitored closely, and the trial excluded some major groups, including people with diabetes and prior stroke. In real life, many seniors are more medically complex than the patients described in trial summaries. That does not make the research wrong. It means it must be applied with judgment. Clinically, what we see is that the body of an older adult has less margin for error. A medication increase that looks minor on paper can mean dehydration after one bad night of poor intake. It can mean kidney strain after a stomach bug. It can mean a sudden drop in standing pressure after a hot shower, a missed meal, or a sleeping pill. And once that instability begins, it can set off a chain reaction: weakness, fear of walking, reduced activity, deconditioning, more frailty. Here's where it gets dangerous. The harms of treatment can show up immediately, but the benefits often take time. Research published in JAMA Internal Medicine suggests that intensive blood pressure lowering may make sense for some older adults with a life expectancy greater than 3 years, but may be less suitable for those with very limited life expectancy, because fainting, falls, hypotension, and kidney stress can happen now, while cardiovascular benefit builds later. So let me ask you something very directly. Are you treating a number, or are you protecting a life? Because that is the real question. In my experience, the most dangerous blood pressure plan is not one that is slightly imperfect. It is one that ignores the person carrying the pressure. And in the next section, I'm going to show you what this looks like in a real patient-style scenario, because this is exactly where many older adults realize, for the first time, that their controlled blood pressure may not actually be safe. The fifth truth is this: the safest blood pressure is the one that protects the brain, heart, and kidneys without stealing strength, balance, and clarity. That sounds obvious, but in real life, it is often missed. Too many seniors are told, "Your pressure looks great," while their body is telling a different story. They are tired, they are slower, they stop walking as much, they grab the wall when they stand, they start fearing stairs, and nobody connects those warning signs back to blood pressure treatment, hydration, timing of medication, or a pressure drop after standing. Clinically, what we see is that numbers can look controlled while function quietly declines. Let me give you a patient-style example that mirrors what I have seen many times. A woman in her late 70s came in with excellent blood pressure on paper. Her seated reading looked impressive. Any quick chart review would have said she was well controlled. But when I asked the right questions, the picture changed. She admitted she felt washed out in the mornings. She had 2 episodes of near fainting after getting out of bed. She stopped taking her morning walks because she felt weak and off balance. Her family thought she was just getting older. That phrase worries me every time, because sometimes just aging is actually under-recognized instability. So we checked more carefully. Sitting, her pressure seemed acceptable. Standing, it dropped sharply. Her diastolic pressure was also lower than I liked for someone with vascular disease. This is the part most people miss. If you only measure once, in one position, you may miss the very problem putting that patient at risk. Research suggests that intensive blood pressure treatment can increase hypotension and possibly syncope, even while reducing cardiovascular events overall. That means the right response is not panic. It is precision. And here is the lesson. We did not treat her chart. We treated her reality. We reviewed timing, symptoms, standing readings, and overall reserve. That is how older adults should be managed, carefully, individually, and with respect for what their body is saying. So let me ask you a very serious question. Have you been told your pressure is good, even though you do not feel good? Because in the final section, I'm going to give you the action plan I want every senior to follow this week, before a stroke, a fall, or a fainting episode forces the issue. So here is the action plan I want you to follow this week. First, do not rely on one random reading. Check your blood pressure at home the right way. Rested, seated, and then again after standing if you have dizziness, weakness, or balance problems. Write down the numbers and write down the symptoms beside them. That combination, numbers plus symptoms, is what gives the real story. In older adults, especially those with lightheadedness or falls, this becomes critical. Second, pay attention to both numbers. Do not focus only on the top number. If your systolic is high, it needs attention. But if your diastolic is drifting too low, that matters too, especially if you feel washed out, foggy, or unsteady. Studies suggest very low diastolic pressure may increase cardiovascular risk in some patients. Third, bring your log to your doctor and ask direct questions. What is my real target for my age and health? Should I be checked sitting and standing? Could my treatment be lowering my pressure too much at certain times of day? And finally, do not stop medication on your own. But do not ignore warning signs either. The best blood pressure for a senior is not the lowest possible number. It is the safest number for that specific body, one that lowers stroke and heart risk without causing dizziness, falls, or loss of function. Research supports treatment, but real medicine requires individual judgment. If this sounds like you, do this test this week. Bring it to your doctor. Do not wait for a fall, a blackout, or a stroke to make this real.